All right. Thank you for attending the 2020 Behavioral Health Symposium. We're happy to host this event as a virtual conference because we care about your health and safety, but we also understand how important it is to provide relevant and robust continuing education to Louisiana healthcare professionals. For quality purposes, all participants will be muted during the presentation. If you'd like to submit a question to the speaker, please use the Q&A feature in the virtual platform. This session is accredited for 1.25 hours for the following: social workers, licensed professional counselors, peer support specialists, nursing, and it's 1 contact hour for AMA PRA professionals. Full participation is required to receive credit and will be monitored throughout this session. You will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Additional information is available in the digital event booklet. Financial disclosures. Adrian Duval and Randy Nichols have no financial disclosures. None of the members of the symposium's planning committee or any session moderators have any financial disclosures. This session is entitled Getting Housed, Getting Safe, Homeless and Mental Health Services in the Post-COVID World. The presenters are Adrian, Addie, Duval, LCSW, Bax, and Randy Nichols. Addie Duval is a licensed clinical social worker and board-approved clinical supervisor. She is presently a regional director for Start Corporation. She received her Master of Social Work degree from Tulane University in 2005. Ms. Duval is passionate about serving those most vulnerable populations in her community. Ms. Duval currently operates both behavioral health and housing programs funded by a variety of local, state, and federal entities. She also has extensive experience in multi-systemic therapy and substance abuse treatment. She serves as a board member on the Louisiana Balance of State Continuing Care Board and has participated in multiple HUD communities of practice. Joining her is Randy Nichols. Mr. Nichols is a United Methodist minister who has served churches in Baton Rouge, Alexandria, and Manchester, England, as well as spending 16 years as the Methodist and Presbyterian campus minister at LSU. Randy has a long history of social justice, public policy, and community involvement, including working with the Bienville House Center for Peace and Justice, the Hospice Foundation of Greater Baton Rouge, Bread for the World, Glasgow PTO, and the Chancellor's Task Force on Greek Life and Related Matters. In 2004, Randy accepted the position of Executive Director of Capital Area Alliance for the Homeless. Under his leadership, Capital Area Alliance for the Homeless became partners in 2 development projects: the Scott School Apartments, an adaptive reuse of an older property, and the One Stop Homeless Services Center and Housing. The projects created 96 units of affordable housing and addresses the needs of homeless populations with disabilities. Randy served on the boards of the Louisiana Housing Alliance, the East Baton Rouge Parish Housing Authority, Mid-City Redevelopment Alliance, Capital Area Reentry Coalition, Bridge Center, and the Housing Trust Fund Advisory Committee. Please join me in welcoming Addie and Randy.
Thank you, Kim. Social sciences writer Malcolm Gladwell has made Murray Barr probably the most famous homeless person ever to grace the streets of the United States. In his 2006 article in New Yorker magazine, he introduced us entitled $1 Million Murray. He introduced us to a man who was 6 feet tall, heavy-set, an ex-Marine, and one who, when he fell down, which he did practically every day, it took 2 or 3 grown men to get him up again. He was missing most of his teeth, yet he had a wonderful smile, and everyone loved Murray. His chosen drink was vodka, beer he called horse piss, and on the streets of downtown Reno, Nevada, where he lived, he would buy a bottle of cheap vodka for $1.50 or so, but when he was broke, he would do what so many other homeless people in Reno did: walk through the various casinos and drink and consume the leftover beverages at the tables. He was well known to the police because they would pick him up sometimes several times a day. He would get picked up, detoxed, and then be back out on the street within a few hours to resume the same process. A lot of the street homeless people were abusive to the police officers, but Murray got along with them beautifully, and they made fast friendships over about a 15-year period. One officer, Steve Johns, told Malcolm Gladwell that he had picked Murray up his whole career, literally. Picked him up to take him to either the police station or picked him up to go to the emergency room, but then he also just picked him up off the ground. He and his partner, another officer, Officer O'Brien, begged Murray to go into treatment. And after a few years, he did. He went into treatment, and it was the equivalent of house arrest, and lo and behold, he thrived. He got a job. He worked hard. He even saved up to $6,000. And then the transitional housing program that he was a part of said, "You've graduated. You're one of our best successes. Congratulations." And they put him back out on the street. Often, when he was too intoxicated for the drunk tank at the jail, he would wind up at the emergency room. So he would be sobered up there, the police would be called, and then they would pick him up so that he could be processed at the county jail. One of the officers, after Murray Barr died suddenly, got very concerned about this whole process, or was troubled by what he had seen in Murray's case. So he began going through police records, and he contacted Gladwell, who went through other public records, and they determined that over about a 10 to 15-year period, Murray Barr had had $1 million of homeless and mental health services, and yet he died homeless anyway. So this gives us a face for homelessness, someone who had spent many years on the streets, but yet somehow the system failed because of the lack of coordination. Now, this is a virtual conference, but hopefully as you listen to this, you might be noticing or perhaps even jotting down some of the things that we learned from Murray's story. Okay, What does Murray Barr have to teach us about homelessness? Well, as you listen to the account of his time in Reno, Nevada, you heard clearly about the substance abuse. You might not have picked up immediately, but he was a veteran. That was one of the first things we learned about him. And veterans are statistically more likely to become homeless than the general population. We also got a little bit of a hint of his mental illness or his inability to manage his life. We heard a little bit about poverty, though Murray did have some skills, unlike many homeless people. We didn't, in his case, hear about domestic violence or HIV. There are other subpopulations that we know are likely to become homeless, such as homeless and runaway youth, youth aging out of foster care, people with a mental or physical or developmental disability. And one thing that was not clear in Murray Barr's story, though, was about the shortage of affordable housing in the United States. And also what was hinted at was the need for coordinated case management, a seamless case management as people move from one program to another if they're going to be successfully rehoused. I want to go back a couple of slides if I can. I think I've skipped. No? Okay. One of the things I didn't want to mention was they also talked about how he was missing his front teeth from falling down so much. And issues of dental care, while it might seem unimportant, at least in the broad spectrum of things, dental care is one of the services that are most difficult for us to obtain for homeless clients. if we didn't have, if we had more time, we might spend some of our time together thinking about the history of homelessness and homeless services. But I think the most important thing to say is that consistently homelessness and the rise of homelessness is associated with some sort of disruption of life in our American society. So it's consistently linked to the economy. When the economy is bad, obviously more people who are living on the edge, people who are at risk of homelessness are more likely to become homeless. But going back for 100 years or more, we see that, that these disruptions in society lead to homelessness, such as to the twin experiences we have right now, a pandemic going through our entire country, and then in South Louisiana, we have added the recent hurricane. We saw Hurricanes Katrina and Rita create homelessness 15 years ago. We saw in Baton Rouge, the floods of 2016 create homelessness. So any of these disruptions are going to necessarily lead to homelessness or a spike in homelessness in our country. Because my wife is an historian, I always have to include some history of homelessness. We won't discuss it, but in 1965, the U.S. Department of Housing and Urban Development was created to address core concerns, and eventually homelessness was assigned to that department. And much of the attempt to end homelessness in the United States, at least on a federal level, is managed by the U.S. Department of Housing and Urban Development. And we locally, all of our communities work very closely with HUD and state and local government to create services or to provide services for homeless people. Homelessness, really the current homelessness issues that we're facing really are born out of a noble intent or a noble impulse, and that is to get people who are inappropriately hospitalized or in long-term care back into their community of origin. However, the problem is frequently services are not robust enough in order to provide the support they need to remain housed. And no doubt many of you see this almost daily or weekly in your work. And if you work with some of the homeless coalitions around the state of Louisiana, you see it every day. The need for more services, whether they are rental assistance or, and then as I mentioned earlier, case management is so important to helping a person move through or from being homeless to being stably rehoused. On any given night in the United States, there are around 550,000 homeless people. Frequently, you'll see in the newspaper stories where HUD announces a decrease in street homelessness or an increase in unsheltered homelessness, or tell us things about family homelessness. These reports know that comes from information that is provided to HUD by all of the homeless coalitions around the country. I will say one caveat, and we might, if there are questions about this later, we can go into more. There are multiple definitions of homelessness, even within the federal government. And so some of these counts include street homelessness, and others also include those who are doubled up or living in overcrowded situations. We'll skip over homelessness in Baton Rouge, and I want to turn over the mic now to Addie Duval.
Thank you, Randy. So today we're going to talk a little bit about the concept of housing as healthcare. So traditionally when we think about healthcare, we may think about more the medical or behavioral health perspective. And I've been so pleasantly surprised to hear, even throughout the symposium this week, is housing being a social determinant of health. So the concept of housing someone in and of itself and alone without any other interventions can act as a healthcare mechanism. So it's very well documented. Lots of research has been shown to show that people are healthier when they are living in safe, affordable housing. And this makes a lot of sense. When you've got a roof over your head and you've got your most basic needs met, it's much easier to tend to those other things. If we think about something as simple as taking medication, first of all, we've got to have the medication. We need to secure it in a dry, safe space. We may need to take our medications at certain times of the day. We may need to take medication with food. All of those things that somewhat we take for granted. However, in living in an unsheltered situation, if you're lucky enough to even have the medication available to you, to be able to store it safely and it not get stolen, to be able to take it at certain times of the day, and regularly, and with food, if you're not sure even when your next meal is going to happen, it's really hard to keep up with those types of things. A clean and dry environment is also critical to hygiene and keeping away infections and other things that can happen in unsanitary conditions. And then the protection from assault and the elements. So there's a safety factor that goes along with having, again, a place where there's a locked door and you can stay out of the elements. Private space also allows for the establishment of stable personal relationships. It's actually been shown to reduce risky sexual behaviors. Yesterday, the trafficking presentation gave us a lot of details about reasons why people may enter into those situations. Homelessness can bring about similar types of relationships and engagement with other individuals where there's an exchange of things in order to provide for those most basic needs. So here, when you have housing, some of those other things do come into place, and you have another bullet point talks about being able to increase our social network and relationships. If you've got a place for your friends or family to come over and to spend time together, that's obviously going to be an increase in those social interactions. If you don't have any family or friends, it's an opportunity to meet neighbors and people in your community and to interact with them. And again, housing may also reduce anxiety and stress-related illnesses, with both of those, being things that can either promote or exacerbate current health conditions. Get my slides. So there are several studies that have been done, and I'll speak about two. This first one I find to be, both of them, extremely fascinating. So this study was done on the effects of housing on hospital admissions. It was Pathways to Housing is a program that was conducted in Tarrant County in Texas. And what it did, it was a great idea. It was a partnership between an insurance company, a local continuum of care, which I will explain in a bit, and some homeless service providers. And so the insurance companies were able to identify those clients that were under their care, that frequently visited hospitals and other areas of service. And they then worked with the continuum of care and other service providers to link them to housing and other supports and case management that Randy mentioned earlier. And in that time, over that 3-year period, you can see all of the decreases in emergency department visits, urgent care, and behavioral health. All of those issues were reduced, and which also resulted in a cost savings of $1.5 million. Similarly, in Seattle, there was another study conducted where they housed 95 adults who were all diagnosed with some type of alcohol use disorder. These sometimes being a group of people that, if they're not clean and sober, they're never going to be able to maintain that housing. They're going to spend their rent money on alcohol. So they housed those people, linked them to, again, the supportive case management, and they were able to show a cost savings of $4 million to that city of Seattle. And the approximate cost of housing per year for each person was only around $14,000. So there's just, in addition to improving the quality of a person's life, there's also a huge cost savings element that I think is critical to look at. Okay, continuums of care. For those of you in the housing world, you are very familiar with these. We'll call them COCs moving forward. For those of you who are not, I hope that you take away from this presentation what this is and how to access one in your own community. So a continuum of care is basically an entity. It's a coalition of providers in an area that their primary goal is to end homelessness. So every area, it doesn't matter where you live in the state of Louisiana, across the United States of America, there's a COC for your region. There are people every day that are working to end homelessness. So part of COCs do a number of different things, but part of what they do is receive money through the Department of Housing and Urban Development that Randy mentioned, or HUD, and they distribute that funding to providers who come up with some really creative projects about how to help people. So the COCs help people who are experiencing housing instability. They may be at risk of eviction, and so we want to keep them in a housing situation. And they also provide short, medium, and long-term rental assistance. And those opportunities are paired on an individualized basis with what people are in need of. Another large goal of HUD that the continuums of care want the communities to be successful is that we want people to become more self-sufficient. We want them to enter back into the community. And so with that said, a big push is to link them to mainstream supports. That could be getting SNAP benefits, Medicare or Medicaid, any of those benefits that could increase their income and just improve their overall quality of life and ability to be self-sufficient. So again, no matter where you live, there's a COC. There's 7 COCs in Louisiana, the 2 largest being in New Orleans, and the other one is a balance of state. And what that is it's made up of 5 different regions in the state of Louisiana that have come together. If you are interested in addressing homelessness, if you have a passion for this population, the COC is only as strong as its members. And so we have members from homeless service providers, we have members from insurance companies, we have members from faith-based communities, volunteers in the community. We have assistance from public entities, state entities, the police department. It's really the best avenue that we have, that their goal is ending homelessness, and it's open to anyone to join, and we're always looking for people. And one of Randy's slides that I want to highlight, he talked about the point in time count. The point in time count is in every community across the United States on one night, usually in January every year. There's a group of people that go out and count the number of people experiencing homelessness, and this data is used to provide support and funding for homeless services. So what was really incredible this year is that in Baton Rouge alone, we had over 60 volunteers who came together with police escorts, and we were really able to canvass almost the entire city and meet lots of folks and engage with them about what their needs were. One other collaboration with the COC that I want to use, because I think it, again, just highlights that we are so powerful together. If we all bring our resources and knowledge together, we can do anything. So we had noticed around Baton Rouge that there were several homeless encampments. And typically what would be done is that someone would call and report, that there was a homeless encampment. Oftentimes it was on private property. And so the police department would go in and try to help these folks, of course, and connect them to services, but ultimately with the end goal of, we need to clean this area up. What we were able to do, the COC worked in conjunction with the mayor's office and also the Baton Rouge Police Department, where the police department was able to give 30 days notice. They entered into a memorandum of understanding that the police department would give the COC 30 days before they would go and disturb the encampment. And that way the COC, in conjunction with the police department, could work with these individuals, engage with them, and try to find some alternate living situations for them before they went in and their entire situation was just totally disrupted, which ultimately, ended up in more chaos. So there's lots of great things that the COC can do, but we need everyone at the table and from all different kinds of disciplines. So I have a link here, and this just, if you are unfamiliar and you don't know where, your COC is, this will give you that information. I'd be happy for you to message me through the app, and I can link you up as well, no matter where you are in the state. Okay, next concept, housing first. So many of us hear housing first or have heard that and may think, okay, yes, housing at first, it's really important. Housing first is actually an evidence-based model. It has not been around forever. It's probably on the newer side. Those of you who have been around for a while may remember the days of you can only get into housing if you're clean and sober. You can only get into housing if you start taking your mental health meds and see a psychiatrist. Housing First actually has a lot of research behind it to show that there's a better way. So it prioritizes providing permanent housing to end an individual's homelessness, which serves as a platform for pursuing their other goals. So it's really guided by this belief that if people's basic needs are met, so housing, food, water, those things are met first, then they can start to attend to those maybe less critical things of looking at their health and getting a job, improving their income, all of those situations. It's rather hard to do those things when you are living in an unsheltered situation. So it does not require the individual to have any of those things in place before they can enter housing. And again, this really, when people enter in and hear about this, it can sound really strange. Like, well, if they are, in the middle of a psychotic episode, or if they are heavily into drugs, how are they ever going to maintain that housing? So as Randy mentioned earlier, it's hugely important that not only do they get that housing piece, but there's also that case management and supportive services. And as we talked about the mainstream linkages that are put into place, that combination has been shown to be hugely successful. The last bullet point on the slide talks about the value of client choice in housing. Again, many times we just think we can walk to a client and say, you have to live here. And they should readily open their arms and be super excited about that. I think that we can all identify that we all like to have choice, especially in housing, as much as possible. And it's people want to live maybe near their pharmacy. They want to live near their church community, near a bus stop, near where their doctor, their psychiatrist, or a hospital, whatever those services that they frequently attend. They may want to live near the school where their children attend. So just because a person is experiencing homelessness doesn't mean that they shouldn't have some option to really have that choice in their housing, because ultimately it does help them to better take care of themselves. So this first graphic kind of illustrates one more time what we talked about, the old way of what we call housing readiness. So this is not housing first, this is housing readiness. You have to be ready for housing. You have to prove that you can be housed before we're actually going to get you into housing. So you see all the way to the left, the person is experiencing homelessness, and look at all the steps that they have to go through to really end up in their own apartment or their own home. So you first got to find a shelter and stay there and maybe prove some things. You got to prove that you can go to the doctor. You have to prove that you can be clean and sober. You come in, you test negative on a breathalyzer, or you test negative on a drug screen. Then we think you're ready for the next step, and we put you in that step into this transitional housing. But then you have to start working, and you have to be able to show that you can pay for your housing. You have to show that you can go out and find things and have landlord engagement and all of those things. And then you get into that permanent housing. But if we look at the second graphic of you're experiencing homelessness, and then you get your permanent housing opportunity. So then you can tend to those less critical, while they still are critical, still less if we're looking at Maslow's hierarchy of needs, their medical, the mental, behavioral, income, and then those landlord relationships, and then leading to life stability. So is it pretty every time when we use housing first? Does it work out on the first time for everyone? Absolutely not. We have to look at stage of change, and some of these people have been unsheltered for 5, 10, 15 years, and housing is a huge deal and a huge transition for them. I think at this point, it's also important to talk about engagement. So I like to use this example of sometimes we think about, we have these conversations. We need more resources. We need more housing, which we do. At the same time, if I go out and I encounter to a homeless encampment, 20 individuals who are experiencing homelessness, and I've got keys, here's a key, and here's your apartment on the other side of town. I can bring you right now and you can have a roof over your head. You would be shocked. I would say at least half of those people are going to say, no, thank you. And we turn them away and we say, well, they're ungrateful, or maybe, they don't know what they're missing out on. How could they turn that down? Who would rather live out in the rain and the cold and the heat? But I'll ask you the flip side. When you go to your doctor and you're not feeling well, and your doctor says, well, if you change your diet and you start exercising, you're going to feel really different. Your life is going to be better. You're going to have more stability. And so that doctor then says, let's hop in the car. We're going to go straight to the gym. And then we're going to go to your house and we're going to throw away all of your favorite snacks and your carbs and your bread and your rice and your sweets. And I would say if the same 20 people, probably at least half are going to say, no, I'm okay. I'm going to do it my way, and I need to take my own timeline. And so the same thing applies for housing. And even though we may not always understand it, it's important on that engagement level is we want to get to know the person, what their needs are, what are their barriers, what are their fears about moving into their own housing. And let's work through those things first, just in the same way we would talk about what are fears, what are barriers to us engaging in healthier activities such as diet and exercise. And then at that point, housing solutions can work, and we can't give up. If someone, again, if we're looking at that stage of change and they're in pre-contemplation or contemplation and we move them to action, but they have a relapse and something happens, we don't have to discard them. We can give them another opportunity. We can set them up in a different housing that may work better for them. So I can't speak enough about the importance of that engagement piece and really learning and understanding the person, and really then moving them into housing and not requiring all of these other things that can be huge barriers. Okay, coordinated entry. So many people say, what do I do? I see I'm encountering a homeless person. I see someone on the side of the street. Someone has come to me. What do I do? Coordinated entry is, in my personal opinion, a fabulous system that's come up. It's got some kinks, but it's actually mandated through HUD. And it really, and I'll show this slide. So before coordinated entry, the left graphic, and I know some, as I was watching the presentations yesterday, it might be a little blurry, but it's a maze. You show up and you don't know what to do. There's lots of different doors to enter, and all different kind of people. You may show up at one door. Oh, I don't have housing. You can go here. So you go there. Oh, we ran out of resources. We don't have anything, but you can go here. It's not very coordinated. It's just whoever shows up. With coordinated entry system, what happens is there are specific access points, and including street outreach, and every person encountering homelessness or experiencing homelessness is assessed using the same assessment tool. It's called the VI-SPDAT. It's a vulnerability index. It actually measures the likelihood that someone is going to die based on their experience of homelessness. And so what's really cool is that everyone is assessed using this same tool. And then when homeless service providers have housing opportunities available, they go directly to that list, which is prioritized by the most vulnerable person, and they say, give me the most vulnerable person, the person that is most likely to die from them continuing to stay in a homeless situation. And then they meet with those people, they find out what their preferences are and what they're eligible for, and they can set them up with those short, medium, or long-term housing assistance choices. So again, coordinated entry system is happening in all of the COCs across Louisiana and across the country. And so again, coordinate with your COC, find out about your coordinated entry system and how you can work seamlessly. We've got a great partnership here in Baton Rouge where we've actually set up a coordinated entry access point at one of our local hospitals. And so when someone comes to the emergency room or enters the hospital, instead of being discharged and saying, go find the homeless service provider, that person gets connected through coordinated entry right there while they're in the hospital. It's amazing. So again, I know all of us that are present today come from different entities, and we can work together with the COC to find those opportunities. Okay. So a little bit about homelessness during COVID. So we know, I think it would not be a surprise to anyone that homeless individuals are more at risk during this time. So a recent study has shown that they're twice as likely to be hospitalized, 2 to 4 times as likely to require that critical care, and 2 to 3 times as likely to die than someone in the general population. So again, very vulnerable. And then even within the homeless population, it really disproportionately affects those people of color. So with that said, you know, across Louisiana, a huge effort was made when COVID sort of had the outbreak here to put people in non-congregate shelters, which are places like hotels where people can be separated. They're meeting with case management. They have a roof over their head to try to link them to more permanent housing solutions, but during this time to keep them safe and help prevent the spread. Some of the housing challenges during COVID. So I'm not going to go through these in detail. They're pretty self-explanatory, but loss of income, both for tenants and landlords. So what makes this time truly difficult is that historically, we've got some wonderful landlords and homeowners or unit owners that are really willing to work with our clients if they get behind, get on payment plans. But right now, those same landlords are struggling with their own financial issues and need those rental payments more than ever. And so it definitely brings about a different dynamic. We've got an increase in evictions, inability to make mortgage payments. So we've got homeowners that may be entering some housing instability or homeless situations more so than during our normal times. Increased rental rates and other things, lack of affordable housing, which is always present. Another one that's been a little different during this time is a halt in construction activity. So we've got some wonderful projects that are going up in affordable apartments, but those have been slowed down or whatnot due to, you know, the workforce decline, people having to stay at home or social distancing measures, even supplies. You know, it's real tough to get certain things that go into the building or furnishing of homes right now. So, not going to go huge into evictions. What I want to go into here, there was a moratorium that did end in July 25th. People had 30 days. Landlords had to give tenants 30 days to exit, and we are obviously beyond that time. Just yesterday or in the last couple days, there's been an executive order that's been put out, and it is goes through December 31st. It applies. There's some eligibility requirements. Again, if you message me, I'm happy to send you more details, but it was actually put out through the CDC, and it will provide some additional protections from evictions, at least through the end of this year. The next few slides go into things about being proactive, both as a tenant and as a landlord. So I've got links to all of these sheets. They're really great. They're 1 or 2 pages. They're very straightforward. So again, if you're working with any clients, if you have family members, if you yourself are having any housing stability, you want to be proactive with your landlord. You want to communicate what your concerns are. The links that are here actually include some ways to initiate conversations with landlords. Ways to, payment plans that are outlined. It's got some great resources that I think its tenants can talk to. What landlords can do, there's options if a landlord can defer or reduce rental payments. They can help people to get on payment plans. They, depending on what the state law is, applying a security deposit or last month's rent to unpaid rent. So again, it's just really important that tenants and landlords work together and that we help those two people to have communication to talk about it. Landlords can also target at-risk tenants. So we want to make sure that we can help our landlords to talk to their tenants about what resources are out there. So if we are able to, and we can do this in conjunction with our COCs, put together resources that we can give to landlords to say, hey, did you know that this agency provides rental assistance, or this agency provides utility assistance, or any other things that we can help landlords to collect rent so that they aren't put into precarious positions as well. It also really talks about that you want to reach out to those people who haven't paid rent, talk to them about what their needs are, see if there's even any ability for them to pay so that we can help to work through those things. And this again goes into including information about available safety net benefits. There's just tons of info out there that's provided through HUD. So these are the 3 places that if you want to learn more about evictions, I think are great resources. Southeast Louisiana Legal Services has some fabulous handouts, and they are kept very up to date about lots of different services, and not only about evictions, but there's some recent things about returning to school, accommodations. Louisiana Fair Housing Action Center has some great resources as well. And then Louisiana Housing Corporation will have information about the rental assistance and opportunities and other programs that they have. They will also have information about the COCs around the state. So again, I encourage you to check out these 3 websites. Okay, the last piece that I'll go into is if you are working with anyone that is, again, experiencing any kind of housing stability or homelessness. This is a whole presentation in and of itself, but I love this concept, 8 dimensions of wellness. SAMHSA has a lot of literature about it. But in this case, wellness is really referring to the overall well-being and being healthy in many dimensions of life. And so the whole concept here is more than just the absence of disease or stress or issues, is that we really want to move, once we can stabilize those things, we want to look at people having a purpose in life, active involvement in satisfying work and play, joyful relationships, a healthy body and living environment, happiness. So if we go back to housing first and the concept of housing as healthcare, this all really ties into this wellness concept that we really need to get the housing in place first, and then we can start to really look at these 8 dimensions of wellness. So why talk about wellness? If you've got someone housed and they've kind of got their, basic needs met, why go there? So data shows that individuals diagnosed with a serious mental illness and who are served by the public mental health system die years earlier than the general population. I know there's presentation and we've heard a lot about ACEs that kind of come into play here, adverse childhood experiences. This same population also experiences diabetes, high blood pressure, cholesterol, hypertension, and obesity at 1.5 to 2 times the rate of the general population. So we're seeing a spike in those issues, which we also know can be a huge cost to our healthcare system. And wellness really does decrease these factors leading to this premature death. So these are the different 8 dimensions. It goes through emotional, spiritual, intellectual, physical, environmental, financial, occupational, and social. And I'll go here. You're not going to really be able to see this worksheet, but what it does is, what I like is it was put out specifically for engaging those experiencing homelessness during COVID. And it goes through each of these dimensions to talk about, and ask questions under each of these areas so that we can really tend to some of those things. It talks about how has your, emotional health changed? How have your finances changed? And it goes into some really open-ended questions to where we can explore those concepts with our participants and learn more about how we can help them and sort of prevent. I think that by asking these questions and being super proactive, we can prevent people from entering homelessness or having some other type of mental health condition, that we can, or that it exacerbates. So again, I think if we take the time to really explore these concepts of wellness and go into these questions, it's a very, very proactive measure. I can't emphasize enough that it's much harder to deal with someone who decompensates, then loses their housing. We've got way more to handle than if we just sort of try to tend to these things as much as we can on the front end. And then these are some of the resources that we went over. So, Randy, I don't know if you had any other comments or thoughts, or if you guys, we can maybe start with looking at, I'm not sure if there's been anything in the chat box or Q&A that we can address. And then we've got tons of other things to talk about, but want to make sure we address what you need.
It looks like a lot of what's going on in the chat box is just comments. Thank you. Just people saying great info, very interesting. We did have one question asking you, Addie, if you can share your citations for the studies that you discussed in the beginning.
I think that they were on one of the slides you mentioned.
Yeah. I think so, but I can definitely share or add, and they should be at the end.
I'm trying to give you some space to get into the frame.
We're trying to socially distance here.
And yet, act like we're. Let's see. I think one of the important things one of the things that's important for everyone to realize, homelessness looks like a very it is a daunting problem. There's no doubt about that. But since the beginning, I mentioned in the 1980s, the deinstitutionalization of people who had been particularly in mental health hospitals, leading to the current contemporary homeless crisis. We have over 25 years of experience in working with homeless people. We know what it takes to rehouse someone, to successfully rehouse them. And a lot of the things that are needed, Addie has referred to, but just think of it as a three-legged stool. You need a rental subsidy, you need an affordable housing unit, and then you need that case management that brings together the resources and addresses the variety of needs. So, and all of these things need to work in conjunction. Again, I mentioned earlier, we've just celebrated the 15th anniversary of Hurricane Katrina. And if you were working in social services at that time, you remember the disjointed way that services arrived. Initially, we had a lot of money put into case management, but nothing put into rental assistance. And by the time the rental assistance money arrived, the case management money had ended. So we were never able to coordinate. And that takes us back to the Murray Barr story, how the $1 million got spent on someone, but it wasn't done in a coordinated way. And so that's really is part of the brilliance of the continuum of care system, service providers coming together, service providers working together. Do you want to?
Yeah, I think another, again, as I thought about how we would, I was so grateful to have this platform to speak about homelessness and housing instability. And I think, again, I can't push enough that if you are interested in an advocate, to join the COC and to be a part of that. So I'll tell you about an interesting another partnership and how we can layer the services that we have and work together. So the agency that I work for, we actually have an assertive community treatment team, an ACT team. For those of you who are not familiar with ACT services, the ACT team consists and is led by a psychiatrist and a licensed mental health professional. They've got nurses on board, housing specialist, vocational specialist, peer support specialist, substance abuse specialist, lots of different entities that really are addressing that holistic piece that we've been talking about. The clients that are eligible for this program are people that have, one of the criteria is frequent hospitalizations or suicidal ideations. We've got homelessness or legal activity that's been happening, our interaction with the legal system. And so here, what we did is, the ACT team is, services are paid for by Medicaid. So we've got that function. And then what we did is we were able to go to the COC and through HUD dollars, get 20 housing vouchers for at least 20 of the clients that are already engaged in the ACT program or who are eligible for ACT services. We can pull them from that coordinated entry priority list, and then we link this really super intensive level of care through the ACT program, but now they also get a permanent housing subsidy. And so we've seen great success in being able to link those entities just in the same way as we put the access point in the hospital. So there's lots of opportunities, and I welcome, I would love to have discussions with those of you who, from some of the things that I've said, could think about those points of coordination, because we need that. We need people in the community and agencies and entities who have ideas, and we can work together creatively, because it's really tough to do this alone. So when we can combine funding sources and layer our services and not have duplication, it can work really well. I know that other service providers in, maybe have specifically targeted, that population that's experiencing HIV or AIDS. And so they've layered medical care with outreach, with a housing voucher, and we've seen some huge successful outcomes with the layering of all of those things. So again, we encourage you to voice your ideas and join the COC, because that really is the entity that's going to be able to promote that. And again, if you encounter someone that's homeless, and we know about it, we can absolutely go and do street outreach and find ways to engage with those individuals.
I think it might be good. Piece again, we've talked about case management a lot, but I think that we also need to understand that there are some tools that case managers need that are really crucial for their work. Addie mentioned acute childhood experiences. These are negative experiences such as the loss of a parent or a significant family member in childhood, and the greater the number of acute childhood experiences, again, the more likely people are to experience homelessness. This has been documented. But as case managers work with homeless people, I think it's important to realize that our homeless clients come from a particular set of experiences, and these need to be acknowledged and dealt with. Many of you that work in social services have heard in recent years talk about cultural competence, but also to talk about being aware of the experiences that people have had and addressing those as part of the case management. Many times the behaviors of our homeless clients don't seem to make sense to us, but that's because they have a different set of experiences. So we need to very much be aware of the trauma that they've experienced in their life. Trauma-informed care and case management is just absolutely crucial if you're going to be successful in doing that outreach and engagement, and then moving people successfully moving them into housing, but establishing a relationship that acknowledges that their experience of trauma, which I would say by definition, if you live on the street, you have experienced trauma. It's just impossible not to have. I don't know, you want to say any more about what your case managers need or some of the...
Yeah, we've got another question, came through on chat. They're asking if there are any housing initiatives for incarcerated individuals that are being released during the COVID-19 pandemic. Are you guys aware of any?
I am not aware of any specific to the incarcerated individuals. Certainly, one of the subpopulations that we've not mentioned in too much detail, though certainly, there are service providers in the continuum of care and in most of the regions of the state of Louisiana and other states that are looking at rehousing of returning citizens. So that is a subpopulation that there are a lot of people working in that area of homelessness, that particular subpopulation, and through the State Department of Corrections, you could probably locate some of those service providers, or through the continuum of care.
Right. I think thank you to the person that posed that question. I think it also highlights another great opportunity. So in previous years, the COC has worked in tandem with the Department of Corrections to put together some different types of housing programs in a really creative way. There was a program that was put together to link people to housing, or really try to just divert them away from the homeless system before they exited an institution. Those people who had identified that they were going to exit. So that was a pilot project. And then we also, for a 3-year period, had a project as well, again, with the COC, the Balance of State COC, and the Department of Corrections, where there was housing provided to those people with sex offenses that were only, their time had been served, but they were still incarcerated because they had no residence. And so we know that that population can be quite difficult to find an appropriate residence. So it really made a lot of sense for a homeless service provider who had really good landlord engagement and linkages within the community to work in conjunction with the Department of Corrections and Probation and Parole to find a suitable living situation and provide those ongoing case management supports and services to help that person be successful. Another project that I can find out more information, I'm not sure if they're still doing it, but there was a project actually that was trying to do some preventative work. So if there was someone that had a bail or something that was going to be $5,000 or less, you could link them to this particular project so that they didn't have to even enter, the parish prison or jail. So there is work being done. And again, we would love to, as the COC, work together with Department of Corrections or any other legal entities in the criminal justice system to try to address, because we know that those people experiencing homelessness really do intersect with that system a great deal. And many times it's, it's not anything that's, real serious offenses.
And that the question about reentering citizens as a subpopulation reminds me anyway, that maybe we've not specifically, this has been implied but not specifically said, that everyone who is exiting a state or federal program or housing that's been provided for them as a result, and I'm thinking about foster care, youth aging out of foster care, similarly to those who are exiting jail or prison, going back out into the mainstream, as it were, are always at risk of homelessness. And the Department of Health and others who are working with Children and Family Services do try to address the needs of those exiting those programs, but frequently there's just such a shortage. But we need to be attuned to the fact that they are more likely to become homeless. And there are some resources, but never enough. I guess the other thing that I always try to wedge into the conversation at some point is the importance of people who are providing supportive services to homeless clients, that they become advocates for affordable housing policy in their community. It's very frustrating to have the case management in place for a person to have a voucher that will pay their rent, and then you can't find a safe, decent, affordable, accessible unit that can pass health safety inspection. And that's what case managers or housing case managers certainly spend a lot of time trying to locate landlords that will work with us, with our clients, and find those affordable units so that we have are able to place our clients. That's a huge issue.
So I guess as we, are getting closer to the ending time, I definitely wanted to leave you guys with some takeaways. When I'm listening in on a conference, I like to feel like I'm walking away with some tangible things of how to help and not just listen to all of the problems and the issues, because most of us as service providers are well aware. So again, I want to highlight this whole idea that I hope that we've been able to impart the importance of housing as healthcare, and the housing first mechanism is that we really want to tend to that most basic need first in order for people to then be able to tend to those less critical needs. I would love for you guys to link to the your continuum of care in your area and to learn more about coordinated entry. But as you're dealing with people who are still maybe linked to those systems and services, and they are coming to you and they're struggling, and maybe you've walked through the 8 dimensions of wellness sheets, some ideas that we've really seen have a lot of success, especially post-COVID or amidst the COVID pandemic, is people are really struggling with medication and keeping up, and are they going to have it? So a lot of pharmacies have gone to increasing, their delivery response and allowing for free deliveries of medication. We've seen some of the insurance companies putting more out there for mail order prescriptions. So if someone that you have is struggling with obtaining their medication, I encourage you to think about those concepts and if that can work. And on the physical level, we also want to look at their ability to just move, whether that's standing up, walking around their apartment, if they've got stairs, even if it's just to stretch or put on some music and dance. That physical activity can be such a huge element of wellness at this point. I think it's important. Yesterday, I know someone mentioned grief. I think that this, when we're tending to the people that we work with, I think to label a lot of what we're experiencing as grief, I was just talking with one of the moderators this morning, and she said that unfortunately, a family member had passed away, and there was going to be a Zoom event. And so I think that as we look forward to the holidays and other planned celebrations, we need to help the people that we serve in planning what those celebrations will look like, while in this world of mask and socially distancing and all of those things. So if we can again be proactive in taking those steps and helping them, and not only saying you need to maybe FaceTime somebody, but we've learned that people may or may not have the ability to use those apps, or if they do, they may not know how to use them or feel comfortable. So taking the time to actually sit down and practice doing those things and helping them plan for those traditions, making new traditions, and labeling it as some of this anxiety, some of this depression that you're going through actually can be labeled as grief. You are missing out on these things. So I think that's a huge factor. And just labeling that they need to be patient with themselves and patient with others as we all try to figure out the different dynamics that are going on right now. Another is we're looking at the 8 dimensions of wellness. I've heard a few times throughout the presentation, again, just, sticking to credible sources, not inundating yourself with news and those types of things that can be somewhat depressing. Creating a gratitude journal. So many of us have not been able to go out and, between self-help groups or faith-based groups and celebrations, we've really missed out on those opportunities. And so how can you incorporate some things that bring you a similar level of joy and a spiritualness that we are all kind of craving right now in different ways? So again, I think that it's between journaling, writing a letter to yourself about what's going on, kind of documenting what this whole time is like. It's such a historic time. Other things that, there's so much virtual things that are going on right now. So I think beyond just giving someone a list of these are the 12-step meetings or these are other events that you can attend, maybe it's to attend with them, to sit in with them, to show them how do you interact, how do you initiate a conversation, how do you do all of these things virtually when you're not in person and have grown accustomed to those skills. Many of the people that we work with, have not the greatest social skills. So we need to practice with them and help them navigate those things. I think as far as income, we know financial has been such a huge burden for people as they've lost jobs or lost income, had to have hours cut, or they're staying home with children. It's really trying to get to the root of maybe some of those financial issues. There's some things that we're not going to have control over, and let's take a look at the things that we do. There's been tons of, and when I say research, but some trends noticed in emotional spending. So we've seen such an increase in, online purchases and things like that. So I think it's exploring that concept of, are you purchasing something because is it out of boredom? Is it because you're feeling down today and you want to have a package in the mail? It made me laugh. There's been a lot of people who are delivery people who have talked about that their trips are taking longer each day because people are waiting at the door for them, because that may be the only person that person sees all day face to face. So again, I think exploring that concept of emotional spending and where can people then have other resources to fill those needs. Making those routines, engaging in those healthy activities. All of these things are things we already know, but I think we have to take another step forward in really implementing and things that are going to be realistic during the COVID time. So on that sheet, that I gave you a link to for the worksheet, there's, again, SAMHSA has a whole curriculum that's related to those 8 dimensions of wellness that goes into detail with questions. And it also goes into detail with lots of other ideas as far as what you can do as interventions. So I think that those things are super helpful and can give you some ideas, again, about being proactive with the people that you serve. I don't know if you thought about any other.
Well, while we're talking about resources, and this was not on any slide because I just thought of it now, but if you go online to the Corporation for Supportive Housing, a national organization that works in the development of affordable housing, but also in housing programs, they have an online training component for case managers and people who are working with homeless clients and those who are having housing issues. And if you feel that like you are maybe at some sort of deficit, this could be something you could provide. It's on your own. It's a virtual training. You don't have to go any place or be at a particular time. So I encourage you to go to the website for the Corporation for Supportive Housing and look for some of the training modules they offer for case managers.
And again, they're just, the participants are just asking for, these links. Obviously, they're, really enjoying the information that you guys are providing, so they want to make sure that we can get links. I know the Women's Foundation said that they'll be supplying the PowerPoint presentations on next week. So you guys out there, be sure that you're looking for that so y'all can get the links to that are provided in this presentation.
Absolutely. I try to include, for most things, again, I'm a takeaway person and I want the hardcore details. So all of the links should be there. But again, feel free to message me through the app. Or if you have my email or whatnot, I'm happy to provide those links or listen to your ideas, help you figure out how to join your own homeless coalition. Would love to have those conversations with you. And I also, again, want to end on the note that we are in the process of moving across the state all of the individuals who are living in those non-congregate shelters or hotel rooms out. So if you are a landlord or if you know a landlord who has housing availability, I know that the governor has put out a call in the past and maybe even recently for Louisiana Housing Heroes, so that you can offer a place and have a safe and sanitary place for someone to go. We've got lots of people in need across the state that were experiencing homelessness, and we definitely don't want to return them to that living situation. So again, kind of from a different angle, if you have any of those contacts, they can call the Louisiana Housing Corporation, and there's actually a list of housing units that they can get put on and get registered, and it goes through if people are searching for housing. So it's louisianahousingsearch.com. So again, I'm throwing out a lot of links, both Randy and I, resources, and we'd be happy to share. Just message us.
Right, and if you feel, well, what is the motivation for a landlord to sign up and do this? Well, one of the motivations is that you have not only the relationship you have with your tenant, but that tenant has a case manager. And so one of the arguments for taking people with housing subsidies is the case manager will work with the landlord and the tenant to make sure it's a successful housing placement. And that's been proven to work well.
So thank you all. I know Randy and I, again, felt very honored to be able to present. Thank you for listening in, and we hope to hear from some of you and who will join our efforts in addressing homelessness.